Awesome. I'll kind of kick us off and then I'll pass it over to Trent. So I'm Andrea Klein, and my background, I am a clinician, and I'm also a industry consultant for Teradata, and really expertise around kind of clinical informatics. And the cytokine storm is a phenomena that happens as a result of many conditions. We're going to talk about that today, and we will focus on, how did this model end up being developed? And then it's actually, we're calling it the connected clinical model because it's progressed beyond the cytokine storm. So what we'll do today is we'll talk about what is the storm, how did this model get built, and we'll give you an interactive demo as part of it. So for the introductions, myself, Bilal, and Trent Seashore will be doing the presentation. And this all started because we had a hackathon internally at Teradata, and I had an idea that we could predict the cytokine storm. And this was a COVID hackathon, and I submitted that idea. It was picked up, and we used it for the hackathon, and I ended up having Bilal and Trent and a number of people help me try to bring this idea to fruition and to breathe life into it. And so Bilal and Trent will help throughout the presentation, and they were part of the development effort. So turn it over to Trent to do introduction and to take us forward.
Sure. Andrea, again, Trent Seashore. I've been with Teradata for a couple of years now, but I was actually a buyer of Teradata when I was at Prime Therapeutics in the PBM space, and I've had a lot of background in the analytics side, so it's good to see Dan and team as well on these mini analytic exercises. So we'll just kind of hop in here. Back in, say, March, we started internal Teradata COVID hackathon. And a lot of people think of Teradata as a database company and hardware only, and we're trying to change that brand because there are a lot of SMEs on the team, to healthcare SMEs and other industry ones. But we built this left hand. You can see a lot of MDs and epidemiologists, and to be able to help clients, payers, providers, others utilize the tools so they can find anomalies, answer our questions and our hypotheses. So really trying to do that as much as possible. And that's really our goal, is to get to the clinicians and say, you already have these tools in place. You don't have to buy anything more. It already comes with the platform, but here's some choices. So it's really morphed into the last 6 months, starting with cytokine. We're working with on the right-hand side, a lot of the large healthcare clients, and using supply chain. So think of the hypothesis of how do we make sure we have enough ICU beds, and especially now as it's obviously still very relevant as our second wave unfortunately is coming into play. So we kind of started a little timeline piece here as we started back in April. Again, on the bottom left, Cytokine Storm tracker, and we'll define cytokine here in a second. But we started with a mimic data set, which was an MIT encrypted data set that everybody could use. And we built the initial model on here, predictive model, over a few days. And Bilal, Andrea, and team were critical for that.
Yes. Sorry to interrupt, but your audio is kind of like in and out. I think because of the mic on your headphones kind of moving. Yeah.
Is this better?
Much better, Trent.
Okay, I just pulled those off. Sorry about that. Okay, yeah, feel as well if needed. And then in May, we took advanced it a little bit further, and we started looking at some different. We had another Veterans Administration hackathon that came up with one of our clients, and we said they had Cynthia data, which is really healthcare data, and we put this model on top of that in May, and a lot of good success. Then we moved into June, and we were demoing this, what we're going to show you today, to our payers and providers, and just to see if this had legs and if it really was as effective as we thought. July, we've actually morphed this into multiple different conditions using different payer and provider data sets. So there's a lot of data that's out, in the public eye that could be utilized. And we're constantly monitoring and trying to advance the Cytokine Storm model. And you'll see that here in a second. So as Andrea mentioned, this model itself is built on Teradata Advantage. And this isn't a pitch at all from Teradata, but it's really using machine learning and AI to ingest and analyze a variety of data sets there. So it depends on what the client has, right? And some data sets may be real time, like Apple Watch data or devices at the ICU bed, or think heart monitors and all of that. And you'll see an example of that. But it could also be, health records, lab results are critical, devices, again, different inputs that we could fit into this. So it's a agnostic tool set that's being built. On the left-hand side here, you can see for Cytokine Storm, but then we quickly pivoted and said this could be used across many different conditions. So it's not for COVID. Cytokine is the result of a lot of different things that have gone wrong. So I'll go through that here in a second. But really in layman's terms, cytokine, and Andrea taught me this when we first started, I think of cytokine as when the body attacks itself, or that's really what's happening. So when you get an infection, our immune system fights that. You may need some help with an antibiotic or something else, but it really is proactively going after the virus within your body. However, if the virus is not contained, it can lead to what they call cytokine storm, which is just and Andrea can explain this even better, but within your cells, it actually flips around and it gets overstimulated and it starts to attack itself. And as we all know, the immune system is very strong. And so when it gets to it ends up being very dangerous. And we're trying to prevent people from getting into the cytokine storm because it's about an 80% mortality rate once you're in. So think of the people that are in the ICU. It's called intensive care for that reason. It is life or death. And so if there's ways we can use this model to predict, just like a hurricane here, you can see any hurricane be now, where is it going? And how, using different models that the National Weather Service does, water temp, wind speed, what's happening, they predict to the people on shore in its path. So they can intervene and make, suggestions or get out of the way of the storm if they can at all. So kind of using that same model, we're just applying, instead of National Weather Service variables, we're using healthcare variables that you'll see here in a second. So just one more visual on the right, this slide is the cytokine story. Again, as we talked about, many different ways to get into the cytokine storm. It's not just COVID. I want to make sure that's clear. It is if somebody has plans and your body rejects it, and eventually you end up getting to the hospital and maybe even going to the ICU rather quickly. And so those late warning variables on the right-hand side here are almost too late. So let's use some of the technologies and tools that we have. Can we do that? That was our hypothesis. If we looked at their lab results and different variables and heart rate and, blood level, oxygen in their blood, can we tell when somebody is progressing down the wrong path? So I'll turn this over to Andrea now on the bottom as we kind of just to explain the difference clinically between COVID and non-COVID.
Yeah, and part of this journey for the hackathon was teaching my colleagues about what is the cytokine storm and how is it different than COVID for COVID than it is for non-COVID. And what we're showing you at the bottom of the slide is that for COVID, the cytokine storm can happen rapidly. So you can develop it in a matter of days. For non-COVID, non-COVID related cytokine storm are transplant rejections. So for example, somebody has a kidney transplant and they begin to reject it, that could be part of the cytokine storm. graft versus host for bone marrow transplants are also the cytokine storm, and it's really a phenomena versus a storm. So it's a set of particular labs that when they all are dysfunctioning at the same time, someone is classified as having the cytokine storm. And so there are early warning variables and late warning variables. And in our model, we wanted to be able to pick up on the early warning variables as fast as possible. And so we have a broad set that we're actually looking at. And when someone enters this cytokine storm phenomena, they can enter through different pathways. They can have respiratory failure, which we're seeing on the news for COVID-19, but they can also have, they can enter through fever. They could also enter through having some sort of a clotting disorder. They could have a stroke or be bleeding. And essentially that's all entering into the cytokine storm. So if we could move to the next slide, Trent. One of the things that we wanted to do with this was to be able to use not only the typical, items, data items and metrics that you think about, which would be things like the demographics and the ICD-9, ICD-10, the DRG, all of that stuff on the right-hand side. But we also wanted to take in variables that were faster moving, so labs and the device and IoT information to be able to give us the predictability and to see this storm coming as quickly as possible. So when this model was built during the hackathon, which we had about, I think it was 48 or 72 hours, and our goal was to be able to predict this thing in as far, as we could in advance. And so, and that was our goal. That was what we set out to do. And as part of that, we were using many of the different tools and techniques that are on Vantage, which is part of Teradata's environment. We were using text analytics. We were doing some clustering. We were also in parallel building this in machine learning. So we didn't know if we'd have enough time to get the machine learning model running with the cutoff with the hackathon. So we did build this model without and with machine learning. And it was interesting once we got done with the machine learning, what we learned, and we'll talk about that in a little bit. So if we can move on to the next slide. And we'll just quickly talk about this. So as we were building this model, we were also saying, well, we want to understand the systems that fail. So the respiratory system fails, and what are the metrics that we need to look for, and how do we find them? And part of the clinical informatics piece was for myself to teach Trent and Bilal and a team of data scientists, what are the things that we're looking for? What are the evidence-based guidelines? And this is just a representation of the respiratory system. If we can move on to the next slide. I don't know if Trent, can we move on to the next slide?
Yeah, I did.
Yep, go ahead. Yep, so we did also look at the solid organs as well, which is, so think about heart, renal, liver. And again, this is using kind of the evidence-based clinical methodology, and we could move on to the next slide. And as we were building this model, remember we're using the National Weather Service, and we had a lot of variables that we were looking at. One of the things that we learned when we applied pathing, which is a visual of what you see right here, was that there were some predictable characteristics of how this storm ended up, deploying itself on individuals. So we found that the most common way was through the respiratory system. And so on the lower left, you can see that the respiratory system was the prominent path that folks would enter the cytokine storm. And if there wasn't quick intervention, full system failure would happen as a result of that. And you can see that at the very bottom right. If there was quick intervention, meaning you put someone on a ventilator, then you could push off that full system failure. We also learned with this was that, you know, folks would enter the storm through a cardiac episode. They could also enter through a coagulation. Remember, this is the clotting or the bleeding that somebody might show up into the ER or ICU. And then the inflammatory is high fever. So as we started to learn the typical characteristics that this storm pattern had, then we started to build our predictive model. If we could move on to the next slide. We were using techniques to try to find the variables. We were using text analytics, and Bilal was the expert with this, where we were searching for particular variables on the left-hand side, which is a little hard to see, but we were looking for lab values and symptoms and all kinds of information that we could include in this model. And we were combing through the medical notes and the nurses' notes. And it was really important for us to have time and date stamps on everything. So we might have a variable that would be interesting, like hemoglobin to us, but if it didn't have a time and a date stamp, it was going to be hard for us to try to do predictive analytics and to sessionize that. On the right, we also looked at what were the typical types of reasons that people were entering the cytokine storm, because remember, not everybody enters through COVID-19. Right now, we're learning about this because of COVID-19, but people can enter the cytokine storm and be in the ICU for a whole host of reasons. And we used word graph for that to understand within the data we were working with. And then we did establish a cytokine risk score for everyone that was in our data set. And we knew when someone would enter the storm, their score would be at a particular level. And on the right-hand side of this, you'll see a score of 13, you are in the cytokine storm. And we wanted to understand what were the types of medications that were being used for people as they were in the storm and before they entered the storm. And this was part of our predictive analytics and part of understanding the cytokine storm. If we can move on to the next slide. In the building of the original model, this was part of the hackathon where we were interested in understanding what are the typical type of folks that will develop the cytokine storm. Are there particular demographics that will eventually get the cytokine storm? You know, are there age and gender differences? Do children get the cytokine storm? Are there certain ethnicities that will develop the storm? And so we did build a model that looked at that, and we also associated mortality rates with the different demographics and with the ethnicities. And if we could move on to the next slide, and we were using clustering techniques when we did that. And remember, I talked about the variables that we were collecting all needed to be time and date stamped, because we wanted to be able to create a cytokine storm score, and we wanted to put these variables together to be able to develop that storm score. And this is an individual over the course of 5 days' time where they about midway become stormy and their score spikes, so they're entering the cytokine storm. And we did note that people who would be entering the cytokine storm often will become stormy, and their lab values become very, erratic and variable as they're entering the cytokine storm. And so this was our first version of the model. And then our second version of the model included the body systems. And so we started to look at the renal, the heart, the liver, the lungs, to say, if we understand these systems, can we even predict further back in time? And I'm going to pass control over, or ask Bilal if you wouldn't mind sharing the models that have been developed as part of the cytokine storm. And while you're doing that, Bilal, we have a question from Bonnie. Is it common for hospitals and healthcare to use IoT information? And I think yes, it is. And in particular, when it comes to, managing people who are really, really sick within the ICU, and for people that have the cytokine storm, you end up having to use all kinds of information to try to manage these individuals to keep them doing well. And as an old ICU nurse, we didn't have technology to help us when I was practicing in the ICU. We had to be able to know this stuff and organize it within ourselves and be able to talk to all the doctors that would be coming in to visit this patient. And so having technology that can bring all of that together for a clinician and organize it, especially if you're working, back-to-back 12-hour shifts, this can be really, a helper when it comes to managing individuals in the ICU. And Bilal, feel free to take it away here.
Thank you, Andrea. So a bit about myself. I'm working as a senior data scientist as part of the offshore team of Teradata, giving support to the guys and doing all the pre-sales and developing all of the work that we've been doing. So basically, what I'm going to be presenting, firstly, can you guys see the screen just to be sure?
See your screen, Bilal.
Great. So what you see on the screen is a similar visual to the slide that Andrea just showed. This is a journey of a patient in the ICU. So as Trent talked about, we were firstly working on the MIMIC dataset, which is all about the ICU patient in the hospital. So this is one of the patient's journey where we have his stay in the ICU for almost approximately a month. What you see on the y-axis is the risk score for the cytokine storm, and on the x-axis is the time interval. Here we aggregated our values for the lab results and the counts for the different interventions on an hourly basis. So that's why you see the time being indicated such at the hour. And the red line that intersects the plot is where you see the current values of what interventions have recently been given to the patient. So the column on the right side of the screen is where you have the interventions that are being given to administered to the patient in the recent window. It's not the immediate hour, but a few hours back, maybe 3 or 4 hours period. Alongside what I have, what intersects the red line is the abnormal values that are relevant to be studied for the cytokine storm that are going out of proportion. So what you see is all of these abnormal readings. On the extreme right is the list that you see. So we kind of give it a real-time flavor to this and just to show that this type of system can actually be present for people to build as a simulator into their operational interfaces forward. So hence you see, this graph is moving, and it gives us alerts every time the score it reaches a certain threshold, which can be an alarm bell for being cautious. So what I can see when I want to do, for example, a drill down into any of these variables that are going, I want to look at the recent history of what's happening to each of these different variables that might be becoming abnormal. I can see what the normal range should be and how much out of range this variable has gone. And I can see the recent history up to that point in time that I want to monitor. So we built this out initially for the MIMIC dataset, and we're continuing to develop this. This has the new interface version, which has the extension to other system failures. So what we have on the top left is tabs for the respiratory failure, the cardio failure, the heptic, the renal. So other types of failure are also being represented now as part of the simulation. What you see as an additional plot here is not only the current cytokine score, but the predicted score, which could be any time step into the future that we're interested in, 24 hours, 48 hours, 72 hours, or any arbitrary number that we might choose to develop this. and hence we can foresee an upcoming abnormality that might occur and a risk to the patient for suitable interventions to take place in time. How do we develop, so just to make it easy for non-specialists, we try to develop an easy-to-use interface which can be quick to build up models and quick to experiment with different configurations of what we want to see. And as Andrea talked about, the cytokine storm prediction can have a series of system failures that could be occurring, as a precursor, and there might be a certain sequence of these failures. So we built out these failures, which were interaction of all the lag values that are relevant for each of these system failures that could occur. So in the purple or blue background, what you see is mostly the lab-related values, and every time we change any particular system for which we want to do the prediction, it gives us a set of suggested variables to select to collect the history for building out the model with. We develop the histories based on a certain time period in the past, so we can choose histories of, for example, up to a day, 2 day, a week prior to the prediction that we want to do. And likewise, on the right side, we have, besides the lab, we have claims data where we have demographic data, the procedural, the procedures that were performed, the devices that may have been used, the medications that were administered, and the recent conditions that had occurred for that patient in the recent past. So we developed this into the model. We can select a model. Our current data is based on the model is based on the Cynthia dataset, which consists of approximately 25,000 patients. So we can either build this model using the complete or any partial subset of the sample that we want to choose from. Again, likewise, we can choose a plain and test split, and we can hit the build model button, which will build out the data. So I've already developed one such model with some example metrics and information about the model that is being output. So what the accuracy might be, as an example, we have certain metrics here. What features were important for predicting the cytokine storm score? So we know that if we knew the current value of the cytokine risk score at this point in time, that would be the most important variable in helping us to predict the next day's score. Likewise, there is variables around the demographics like the gender and the age and the ethnicity that this model considered important in doing the prediction. And hence we see these variables with all of these variables with different importance values being assigned to them. So over back to you, Andrea. This is all from my side, unless you want to add something there.
Yeah,
I think, Bilal, if you unfollow, and then I can bring up the slides again.
Yeah, go ahead. Yeah, while you're doing that, there's been a few questions in the chat box that I'm trying to respond to. So for folks, the model was originally built on the MIMIC data set, which was inpatient hospital data. And we did have some history with that MIMIC data set where we're able to try to define what happened to these patients. And I know there was a question about that. We moved this and shifted this model over to the Cynthia data set, which was a little bit different than MIMIC. And the Cynthia data set is synthetic, but has history. And we used the same methodology when we shifted the model to Cynthia. We did have to adjust some of the methodology because we frankly had a little bit more variables to include and a greater history, of which Bilal just showed, where we can actually go back in time historically. And in the Cynthia data set, you have the person from the birth till death and their history. So, and that is the last model that Bilal showed was shifted over to the Cynthia data set. And that was done for another hackathon that we participated in that was hosted through the VA. Our hackathon at Teradata our goal was to try to predict the cytokine storm in advance. How far in advance could we see it? This was using the MIMIC data, and we could predict it 36 hours in advance, and our accuracy was about 70% on the accuracy. Now, keep in mind, we had about 48 to 72 hours to build this model. We were building it in machine learning and not in machine learning. And we did those in parallel racing to try to get to the finish. We did win the hackathon with this model. And what we learned from machine learning was we needed to open up our variables. And we needed to look beyond just the things that define the cytokine storm when you develop the risk score. And we did that, and I know there's been some questions in the chat about that. On the other thing that we did with this was once we completed the hackathon, we started to look at this model, and we were being asked by some of our clients around, you know, what do the interventions do to the storm score? So we specifically honed in on the medications that were being delivered to individuals who are in the cytokine storm. And what we did was we looked at, you know, what is the impact? And in this slide, you can see that mannitol and daptomycin and levothyroxine, these all had significant impact within an hour after the delivery, and it did drop the score dramatically. On the far right, metoprolol, it's a beta blocker that stabilizes the heart, had a very minimal impact on the storm score. So this was really to try to think about how do we help people who are within the cytokine storm. So what was next after we participated in both hackathons? We had folks asking us, could we take this risk score that we established and could we stratify a population? Could we look at people with the lowest risk and identify them? And could we, you know, particularly focus on the moderate risk? And how, you know, who are these people that are in moderate risk? Can we find them early? Can we intervene early? And could we start therapy on them early? Was the question that we were being asked by our clients. And the highest risk, these are the people who are already in the ICU. They're already in the storm. And so really what you saw Bilal show was the operational management tool where if someone's in the ICU, you could use this. So if we could move on to the next slide. And we'll move through these slides fairly quickly. So this is a dashboard that was developed, and this is a sample where we can show a chief clinical director, medical officer, you know, for a payer, for a hospital system, where are these people, who are these people, and tell us about the people who are in the moderate risk. You know, what are the demographics? Have they had a COVID test? Have they had a flu vaccine? The other thing that we were asked to do as the model was developed was to think about the cost of care. So the model shifted into the cost of care, and we started looking at what were the daily costs of somebody fighting the cytokine storm or as they were building up into the storm. And we started to see patterns that as someone was building to the storm, the costs were escalating. But once they determined that the person was in the storm and started to treat, then the cost started to decrease. And if we could move on to the next slide. This is a sample view of where we could look across the U.S. to see who is at risk, and this was something that we were asked for one of our payer clients, and if we could move on to the next. And then we were also asked, could we give an individual client list? This is a sample, and could we identify particular things that were interesting, you know, whether it's the daily cost, their score, their COVID status. We were also asked if we could embed this in existing dashboards, you know, so for example, this is an epic example where they have a sepsis dashboard that exists, and could we embed a cytokine score within that? That becomes an operational clinical discussion, but yes, we can embed that, and we did embark upon that. I'm going to pass this back over to Trent to talk about the model evolution, because it did evolve into cancer.
Yeah, thanks, Andrea. I think, as you were mentioning, for sure, and I think in any of these data science predictive models, your original hypothesis, you may have a yes or no answer, but you find other things as you have more data. And I think that's kind of the theme of this, is tried to build it in a way that was agnostic. So it started with COVID and trying to, because that was very visible and real to everybody. But as we kept going on, a couple of our clients had said, we feel we have the identification of COVID down pat, and we're treating them and going through, but could this be used for other conditions? And we said, absolutely. You're just asking the machine to do something different. So now think about cancer, and somebody's going through their journey. What variables and what things could we see in their journey itself? They may have additional variables that we want to look at. So you can kind of see on the right-hand side here, if there's ways to treat different chemotherapy or radiation or others, each patient's journey is slightly different. And that's the art of medicine. So how do you actually use it on this path? So you see this, again, clinical model doesn't have to be only for COVID, could be in this particular example, cancer. Let's look at the markers. Let's look at genetic testing if we have. What treatment regimes might we be looking at? And trying to use any data source, either internal to the company, to the client, like data set or something else to feed in and let the machine do its work. So just real quickly, one of the examples was in renal failure. If there's some renal cancer, if somebody's going through this chemotherapy treatment, you can kind of see patient C on the bottom left here. Here's what their score is, that we've kind of put together. Their bilirubin is on it, said their creatinine is X. If we do this one drug here in the middle, this, I won't even try to pronounce it, but a chemo drug failure, if we give just one more dose of that, is that going to tip them into the cytokine storm, yes or no? So as we all know, through the cancer journey, sometimes, you're putting poison in the body and it kills everything. It doesn't know, and then you have to back up. But if there's ways that we can decrease the nausea, decrease the and affecting all these other systems, that would be very advantageous for that patient. So still be effective, in killing the cancer, but maybe not killing everything else in the body. So we just tried to use that individual impact to say, yeah, let's start using the variables accordingly and manage the care of this cancer patient maybe in a little bit different way. So it's more data sets, right? And then Andrea, just kind of in conclusion, if you want to take that over.
Yeah, in conclusion, this really started as a hackathon idea, from Teradata. I had this big dream idea that we could create a cytokine storm model and a tracker, and I had this team of folks who you guys have met, Bilal and Trent and others, help me breathe life and to try to figure out if we could actually make this thing work. And we were able to do that. And how is this model, continuing? Well, we've had lots of conversations in the chat where folks are asking, is this a model that exists today in the healthcare system and in the payer, part of the world? It does not exist today. And this was born out of me being an ICU nurse taking care of patients over a long history of time, and an idea that that we brought together, and we did have a lot of experts helping us with this. So the model has pivoted to people who are interested in the system failures that were built as part of the cytokine storm, and folks are interested in the cost of care with this. There are a lot of conversations around the being able to help hospital systems identify people for early intervention, especially with this next wave of COVID happening. I'll conclude. I know we have a few minutes left. Do folks have questions? And Kim, do you want to open up for questions here? Thank you. Thank everyone. Thanks everyone for attending today.
Thank you.
Yeah, thank you. Thanks to the three of you for a wonderful presentation. We're actually 2 minutes over, but that's okay. We actually have a longer break after this talk. So our next talk is at 10:45. So go take a break, get a glass of water, and also take some time to network with other attendees through the networking area. So thank you all so much, and we'll see you again at 10:45.
Thank you. See you guys.
Thank you.